Thanks for coming, everybody. Moby Parsons, Dave Thut, and we're both joint replacement surgeons at Seacoast Orthopedics and Sports Medicine. We're here to talk tonight about the ConforMIS knee, which is probably, I think, one of the more exciting advancements that's come down the pike in joint replacement surgery, and will soon be expanding into hip replacement. And this concept has been around probably for 6 or 7 years, but it's been sequentially perfected over the years, and now is really taking advantage of some of these technological developments like 3D printing and allowing for literally custom knee replacements that are custom made for each individual patient. So if you think about that, that's really a pretty profound advancement where we can now build artificial joints that are specific for each patient's anatomy. And the concept is that that's going to lead to better outcomes, more functional knees, better durability, knees that are more stable. And what we're going to do tonight is just talk a little bit about knee arthritis, and then we'll sort of go through the whole philosophy of why ConforMIS is such a good product, and sort of what the deficiencies are with some of the current off-the-shelf knee replacement systems that we contend with as surgeons, and how those may manifest themselves in ways that lead to patient dissatisfaction, and how the concept of a custom knee addresses some of these issues. And then we'll sort of play a little video on how these things are made and the whole sort of manufacturing concept behind it. The other thing is these things are made right down the road. The plant that manufactures these things is in Bedford, New Hampshire. Actually, I took a tour of it yesterday, and it's quite amazing. I mean, these 3D printers are just pumping out these cutting blocks, and it's quite amazing to see that they can literally create each one that they're making is custom made for an individual patient that will then get boxed and shipped. So next slide, please. And next slide. So a little bit about the knee, just for starters, so you guys have a background. The knee is composed of 3 separate joints. So the femur bone, tibia bone, patella or kneecap. And when we think about arthritis, there's a medial compartment here on the inside, so that would correspond to this part here, a lateral compartment on the outside, and then the compartment behind the kneecap. And each one of these things, can be involved with arthritis. Next slide, please. And basically, the way a joint works is that you have cartilage, is the smooth white stuff that covers the bone. It acts like a smooth gliding surface. It's frictionless, so it has less friction than if you took 2 ice cubes and rubbed them together, and that's why we can move around all of our lives, without pain. And it distributes loads so that as we go through our daily activities and our sports activities, the cartilage is really what's taking up some of the impact and allowing our joints to move in a fluid fashion. But unfortunately, for a variety of reasons, which probably includes some genetics, some wear and tear, some trauma, and probably some reasons that we don't fully understand, this cartilage can break down over time and essentially wear, and it may start off as some fissuring or cracking, and then eventually you can get areas where there's completely exposed bone like this. And then gradually, it tends to be a progressive disease, so as this starts off, it may be mild, and then as it wears, and then you can get mechanical deformity and contractures of the joint and stiffness and all these other problems that basically limit joint function and cause pain. Next slide, please. So patterns of arthritis, because there's 3 separate compartments in the knee, there are several different patterns where sometimes people will have arthritis that's just limited to the inside part of the knee, like this. Other times it may extend into the joint behind the kneecap. And then in some people, it'll progress to involve the entire joint. So we call this unicompartmental, meaning one, bicompartmental, or tricompartmental is when the whole joint becomes involved. Regardless of how extensive it is, even when the arthritis is just in one compartment, it can be very debilitating. So you don't have to have tricompartmental arthritis, to have a really bad dysfunctional knee. Next slide, please. Joint replacement is sort of the end of the line treatment. So when people present to us with knee arthritis, we typically like to start with the sort of lower risk conservative treatment options, weight control, exercise, anti-inflammatory medications, injection therapy, brace therapy. That's sort of the gamut of conservative treatment options for arthritis. But when people run through that gamut, eventually pain takes over for people. And pain is a sort of great motivating force. When people get to be in enough pain and their function is significantly compromised and they can't do what they want to do, and you've sort of run through conservative treatment options, unfortunately we can't regrow cartilage. People are working on it, but science hasn't really solved that problem yet. So the best that we can do is put a new joint surface in there. And so, with the aging population, the number of joint replacements, knee replacements alone, is up to 600,000 a year in the United States. And that number just sequentially keeps going up. So if you look at growth projection curves as the number of people who are in that 70 and older, baby boomers coming of age, this number is just going to keep going up and up and up. So this represents sort of a burden of disease that the orthopedic community has to contend with. And as people get older, they're more and more functional and they have higher physical demand. So people always say 60 is the new 40. People that are 60 and even 70 are running, they're doing a lot of activities. They're skiing. And so when we put these joint replacements in people, their expectations are they want to go back out and return to a lot of those activities. And so that sort of puts the onus on us as the people that do this, as well as the industry and the engineers that design these things, to come up with solutions that are going to meet the demands that people want, particularly as we see more and more of these. So
next slide. So I don't know why this isn't picking me up quite as well as it picks up Moby, but can you all hear me? So when you've come to see us, or you've seen your primary care doctor, your physical therapist, you've been through all of the non-operative things that there are to do, which, as Moby talked about, include injections, bracing, all those sorts of things. And you're at the point that none of those options work anymore. It's time to consider something more drastic. And you're looking at a total knee. What is it that a patient wants to get out of a total knee? And what a patient wants to get out of it and what we want to get out of it aren't necessarily the same things. So what a patient typically wants is range of motion. Your knee's feeling stiff and sore and you can't get around very easily. It's hard to get up out of a chair. You want your knee to be able to move normally. A lot of people's knees don't quite come straight when they've had arthritis for a long time. You'd like your knee to come straight again because it's easier to stand up and stay erect or with it straight. You want your knee to feel stable. So a lot of people with arthritis, because of the pain or because of the deformity, the knee starts to give out on you. The knee starts to feel as if you can't trust it. And you want to be able to trust your knee. So people want stability. Fit. You want the knee that goes into you to fit your bone. You want the implant to look like your knee did, or to work like your old knee did, or as close as it can. Function. You want to be able to get around. You want to be able to do the activities you hope to do. You want to get back to playing golf. You want to get back to hiking. You want to get back to just working or walking around without pain. Durability. You want to be able to bang on your knee a little bit. You want to be able to use it. You don't want to have to feel like you need to baby it all the time. And longevity. You want this thing to last, right? So knee replacements in general, we tell people last somewhere in the 15-year range, although it's hard to predict for any given person. If we can get that longer, the longer it takes, the longer the thing will last, the less likely it is that patients will need to have it redone. That's certainly what they're looking for. Next. So what are we looking for? Well, we want patients to be happy. Patients come to us because they're dissatisfied with their activity level, they hurt, and we want to fix that. Predictable outcomes, we want to fix that predictably. We don't want to have some people get better and some people not get as much better. We want to predictably tell people to be able to look at you up front and say, we're going to do this operation and this is what you can expect. We want reproducible outcomes. So again, we want to be able to know that in this situation with this x-ray and this amount of arthritis, this is what we can expect. And then we want as few complications as possible. There are a lot of things that can go sideways with a knee replacement, and we want as few of those as possible. Next slide. So how do we do with that at this point? About 80% of people, if you look at the studies, are pretty happy with their knee replacement. But about 20% are not as happy as they'd like to be. So that runs the gamut from the few people who really feel like, man, this really hurts and I wish I didn't do this. There aren't all that many of those. And about 80% of people, 75% of people feel like, geez, this knee feels really good. I don't think about it anymore. And then there's about 20% of people who say, you know, geez, this feels pretty good. I'm glad I did it, but I wish it didn't hurt when fill in the blank. And so What we'd like to do is to improve that number. We want this group of people who are having low-level pain and discomfort, that 20% of people, to feel better. So next slide. So this is just a list of studies that are out there looking at dissatisfaction after total knees. And you can see there's a whole list of studies in the published literature that range all the way from 11% of people dissatisfied up to 40% of people dissatisfied. Next. So why is that? So there's a bunch of things that can drive dissatisfaction. The first is that the thing doesn't last as long as we wanted it to last. So that can happen. The implant can fail quickly because the alignment isn't set up right. So the way we make these cuts is very important. We need them to be at exactly the angles that they should be. The implant can wear out, so the plastic or the metal doesn't last as well as you'd like it to. The engineering makes it hard for the implant to function well. So the ligaments don't stay well balanced. The knee ends up feeling unstable and feeling funny. People have residual pain. So part of that, again, can be that the alignment of the implant isn't quite right, that the fit of the implant isn't quite right. And we'll have pictures, but this is what this ends up looking like, is a piece of metal that's over the bone. If this piece of metal is hanging over by 4 or 5 millimeters, it can rub on the soft tissues around it. That can cause pain. If it's too small, it can cause pain. And then compromised function. So if people remain stiff, can't get their knee moving, have instability in their knee, they're not very happy. Next. So the top 10 reasons for knee replacements to fail early, or for people to be unhappy enough to consider repeat surgery. The first one is unrealistic expectations. So that's our job, is to help you understand what you can do with your knee. On the other hand, we want to maximize what you're able to do with your knee. Wound healing problems and prolonged observation of draining wounds and infection are all sort of go along together. And those are things that can happen as part of an early complication after surgery. And most of those, frankly, are related to patient-specific issues. Do you smoke? Are you overweight? Do you have diabetes? There are a whole bunch of things that increase your risk of having an infection or having that kind of stuff early on. But then there are a lot of things that have to do with how we put the implant in. Is the implant rotated correctly relative to the bone? Is the cut on the tibia, on your shin bone, in the right angle, or is it angled one way or the other? Have we corrected your knee so that when it was either bow-legged or knock-kneed, have we gotten your legs straight? Does your kneecap ride the way it's supposed to? Are the ligaments balanced so that they don't end up being unstable? And those are all things that have to do with the design of the implant. And then the final one, operating too early, is, again, are your expectations correct? Did you have some mild arthritis that we sort of ended up offering you something that was too early for you to do? You should have stayed with injections for a while longer.
So if you look at how off-the-shelf implants are made and sized, and these are sort of the conventional ones that we've been using and we still continue to use in a lot of cases, you know, the industry to date, before we had custom knees, had to pick a range of sizes, you know, kind of like shoes. You know, there's sort of a range from like 1 to 12 with some half sizes. Knee replacements don't have half sizes. They're like 1 through 8. And so the way that they come up with these is they basically take 10,000 data points and they plot them along an axis, and they look at the dimensions this way and the dimensions that way, and there's a lot of variability in the population. And so what they do is they then use like an Excel spreadsheet function, and they draw a trend line through the data, which is this blue line right here. And then what they do is they take 8 average points along that trend line, and that's how they come up with the sizes of their total knee. So if you happen to be right along the trend line, one of these things will probably fit you reasonably well. But if you're one of these outside people, you know, who's up off the trend line here, chances are good you're not going to have optimal implant fit. And so this is sort of, you know, the best that we can do leading up to modern day technology. And really what we're contending with is like the law of averages, is we're trying to sort of make everybody average. Next slide, please. So, you know, what ends up happening when we try to take these average size implants and fit them in people who are outside the averages is we get problems. You know, we get sort of a conflict between the patient's anatomy and the implant size, and this leads to improper fit. And that can either be the implant overhangs, like this right here, where you see that it's overhanging the bone, and that's going to rub on some of the soft tissues around the joint. Or you can have underhang, where you have exposed bone here that may bleed post-operatively. And so these fit positions, you know, can be issues with residual pain. So there's literature out there, that says overhang is painful. People have studied this in the literature and found that 27% of persistent pain is because the femoral component is off the bone somewhere. Next slide. And then implant malpositioning. So if you put these things in wrong, you can have problems where the kneecap here dislocates off the side of the femur. You can have issues of this is gross instability where the knee dislocates, but you can have deformity where people are still walking around on a knee that's not bent right. You can have limb length shortening. And so these are all issues that we have to contend with if we're taking things that are averagely sized and trying to put them in non-average people. Next slide, please. So, why do we need personalized solutions? It's because knees are like snowflakes. There's no two knees out there that are exactly the same. And people always say, don't you get bored like doing the same thing over and over again? Like if you did knee replacements all day long, wouldn't that kind of get boring after a while? And the answer is every one is different. Every pattern of wear is different. Every patient's size is different. So you can look at these here and you can see here is, medial compartment arthritis, which really collapsed on the inside here, but it's kind of well preserved out here. This is worn all the way around. Here's one where it's mostly behind the kneecap. These are all, no two knee arthritis situations are alike. Next slide. So, and again, here's one where like the kneecap is sliding off the femur, and here's one where it's pretty well centered, but they got a lot of bone spurs around it. So, it's the same basic animal, but each one is sort of a different beast that we have to deal with. And so this is sort of a good rationale for if we could have like custom solutions for each problem that we encounter, that would go a long way to ensuring that we put these things in right, that they fit right. Next slide, please. So, that's where the concept of ConforMIS came along. And this was actually started by a radiologist who realized that as imaging data got more sophisticated, you could use CAT scan data to develop a three-dimensional model of somebody's knee. And then you could basically translate that into the design of an implant using sophisticated software design and computer algorithms to try to restore knee anatomy. And so they came up with this concept of, one patient, one implant, custom designing an implant for each individual patient. And that's sort of the rationale behind the ConforMIS knee.
So when the engineers are designing a total knee, what are the ConforMIS engineers looking for? They want, as we've talked about, they want the implants to fit specifically for you. They want the position of those implants, where they sit on the bone, how they're rotated on the bone to be specific to you. Mechanical axis means how your knees, whether you're knock-kneed, bow-legged, whether your legs are straight, whether those are exactly right. When we make the cuts on the bone to put these implants in, the more bone we take away, the less bone there is if you need to have this done again 15 years from now, 20 years from now. So we want to take as little bone away as possible so that it's easy to revise this if it needs to be revised later. Preferably it wouldn't be revised, but we want it to be as easy as possible later. We want it to be optimized so that it doesn't wear too fast. And we want it to be delivered to the system, delivered to the hospital, delivered to the patient in a way that's efficient and cost effective. So the way this works for ConforMIS, again, is that the first step is you obviously meet with one of us and say, okay, this is what we're doing, and it's time for a total knee replacement, and we're going to go ahead with this. And then the CAT scan, so what a CAT scan is, it's an X-ray type, it's an X-ray, but it's an X-ray that's taken in 3 dimensions. It takes sections of you, and from that they can build a 3-dimensional model. So the first thing is to schedule and get your CAT scan of your knee. And they actually take a CAT scan of your knee that includes your hip and your ankle. So from that, they can build a model of the alignment of your entire leg, and they can build a 3-dimensional model of what your knee looks like exactly. So then they recreate your knee on the computer screen, and then they personalize the implant. So they use algorithms to say, this is the way that we're going to design this implant so that it fits your knee. It's not an off-the-shelf standardized one. It's actually designed to fit you. And then once that implant is built, and that process currently is taking about 8 weeks, it's delivered directly to the hospital, directly for you. All of the jigs, everything is in this one box that comes, and we get it into you and get you back up on your feet and get you going. Next. So one of the things that's a challenge in one of the biggest challenges in designing a knee implant is to have it feel stable. And the ligaments on the inside and the outside of the knee need to be tight enough so that your knee feels stable, but loose enough that you can move your knee and that it feels easy and glides easily. So the way that typically has been done is to choose one model of how we think that arc of motion ought to go through. With this ConforMIS system, where they can design it based on the arc of motion that you had in your knee. So next. So there are, again, a number of different theories that different companies have had about how to design that arc of motion. And you can see here that if you look from the front of the knee, this is the front of the implant all the way back, the ligaments that start here in the middle and need to go out to the side should be the same length all the way through. So again, the ligament that would start right here, this is looking from the side of the knee, the ligament that starts right here and comes all the way here should stay the same length whether your knee's straight or whether your knee's bent. So next slide. So different companies have come up with different ways to do this. You've probably seen advertisements for the Stryker. It's called they call it the get-around knee is what it is on the TV. They show people on bikes with an oval wheel, that kind of stuff. And so the idea here is that they make a circle back here in the back of your knee so that those ligaments should stay the same. Zimmer tries to make a circle, but their circle's different. It starts at a different point. It has a different angle all the way through. Nobody really understands exactly how that circle ought to go. DePuy's done it even a different way, trying to make a circle that's the same size in here. Next. Here.
So currently, all of these designs basically show that nobody knows what the right circle is when it comes to figuring out what the curvature of the femoral component will be. And that's because there is no one right circle. It's different for everybody. And so really what we need is an implant that respects the geometry of the patient's bone so that we can put in a circle that fits the circle of your knee so that when it moves, those ligaments stay stable. And so what the CT scan allows the engineers to do is exactly approximate those curvatures, that circle in the knee, and then build a prosthesis that basically keeps all these relationships the same. So we want the level of the joint line, right here, where that joint line is in relationship to the ligament insertions, and where the back of the cartilage is in relation to these ligament insertions. We want that to be the same as the way it is in your natural knee. And so what they do is they design an implant like that fits that shape exactly. So that's what the custom implant is. And it basically restores all of these natural offsets, the distal offset being the level of the joint line and the posterior offset being the level of the back of the cartilage on the femur. And that's basically the entire arc through which the knee moves, where the ligaments have to stay stable. Next slide, please. So hit the button again. So these are some videos. And in a normal knee, as the knee flexes, the tibia bone rotates backward. The femur bone rotates backward on the tibia. We call this lateral rollback. So if you look at this video right here, here's the femur. As it goes through flexion, you'll see this arrow, the yellow arrow, rolls back on the tibia. This is the way a normal knee functions. And this is a sophisticated study that was done by a guy named Komistek, who's looked at this using live x-ray. And when he looked at people doing a deep knee bend and a chair rise after a ConforMIS knee, what he found was that the lateral rollback exactly replicated a normal knee. And if you compare that to some of the off-the-shelf designs, this is a Biomet design, you can see that this movement is much more erratic. As it goes through a range of motion, there's some forward slide, there's some backward slide. Click it again. And click it again. And same thing here with some of these other off-the-shelf implants. You see this one here is actually sliding forward. So the Zimmer Next Gen, there's actually forward movement as opposed to lateral rollback. Click it again. And finally, this is the Stryker Triathlon knee. And you can see this one's all over the place. There's some forward movement, there's some backward movement. And so we call this paradoxical movement, where it's supposed to be rolling back, but as you're going downstairs, it's actually rolling forward. And that paradoxical motion translates into stress in the soft tissues, which can cause pain. So it's not normal mechanics. Next slide, please. So, in terms of restoring normal mechanics, we now have good mechanical studies that are giving us comparative data where we can compare how does the ConforMIS knee function relative to these other off-the-shelf implants? And what you can see here, 91% of ConforMIS knees implanted function pretty close to normal compared to just 56%. What this means is that 44% of these knees are having paradoxical motion. That's almost half of them are moving erratically when you put them in patients. And same thing. And then liftoff, and we'll talk about this a little bit more in a minute, is basically where the femur bone actually, the femoral component lifts off the tibia bone during motion. People will say, it feels like it rattles, it feels like a clunk. 0% liftoff with the ConforMIS knee compared to 56 for off-the-shelf designs. Next slide, please. So all these things like preserving the joint line, getting these relationships right, it's critical. It's critical to how the kneecap functions. If you elevate the joint line too much, your kneecap may be too low, and you may have problems with instability. When the knee comes into mid-flexion, the ligaments are loose and it wobbles around, and then people get swelling and pain in the knee. And if the joint line is too low, if you don't resect the bone right, you may have problems with stiffness. And so all of these little relationships between where the joint line is relative to the ligament insertions, they're key to how knees function. So although this seems like simple carpentry, it's a very nuanced, fidgety operation trying to restore all these mechanical things, to get the knee stable and functioning well. Next slide, please. And so, having a personalized shape and fit, if you think about it conceptually, it's the best way to do that because everybody's knee is different. So the only way that you can account for the variability in patients' anatomy is if you have a personalized solution that's custom for your knee and the ability to put it in so that it matches your native anatomy. And that's what ConforMIS gives us.
So one of the things, Moby's been talking here about the fact that the shape of the femur affects how those ligaments work as you bend and extend your knee, bend and straighten your knee. The second place that people have trouble and have pain is underneath the kneecap. And the kneecap can feel unstable. You can have pain. You can have feelings of weakness if your kneecap isn't appropriately aligned in the little groove that it has to run up and down. And it turns out that getting that kneecap well aligned is dependent on getting the implant that goes on the top of your tibia, on the top of your shin bone, correctly rotated. And the reason is that if you rotate the tibia, if you rotate this component differently, the components will align to meet one another. So if this component that goes on the top of your shin bone is in here in the wrong rotation, what that's going to do is make your foot turn out or make your foot turn in because the implant's going to find where it wants to be. And then your foot sort of go in the direction that it needs to go to make that implant happy. And what that does is makes it so that the tension on your kneecap, on the tendon that goes to your kneecap, is pulling in the wrong direction if you don't get that alignment exactly right. That kneecap tendon, patellar tendon, needs to pull in the way that it was designed to pull on your knee. So in a traditional design, the tibial tray, the component that goes on top of the tibia, has a standard shape. And again, this is just an average shape that's based on a plot that they did to get an average shape. Well, if it turns out that your knee doesn't have that shape, we end up stuck with having to choose, are we going to put the component slightly rotated so that it fits the top of the tibia, or are we going to rotate it the way it's supposed to be, but then risk the fact that it might hang over the side of the tibia? So we end up having to make some compromises when it's just a straight off-the-shelf component that can result in pretty significant change in rotation of that component, and that can affect your kneecap joint. Next. So there are a bunch of studies that look at this, and basically patients with internal rotation of the component are 5 times more likely to have pain in the front of the knee, anterior knee pain in the front of the knee. There are several studies that have shown that. About half of all residual pain in total knees can be caused by or can be explained by tibial malrotation. So by that implant going on top. So of the 20% of people that are still having trouble, half of those are because that tibial component is not sitting correctly on the top of the bone. Next. So what ConforMIS is able to do is to look at what the top of your tibia actually looks like. And if your top of your tibia has a center here, they can create an implant that actually fits the way the shape of your bone is. And therefore, we can put the implant, not only does it show us the rotation of the implant because it fits the way that it fits, that assures that the rotation is correct and the kneecap's going to track correctly. And it assures that there isn't any overhang of the tibia so that it's not hanging off one side of the bone or the other. So it's set so that we can allow a little bit of adjustment, get everything lined up, but it basically doesn't lock us into having to make compromises. Next. So the next thing is overall fit of the implants. So with a traditional implant, what we do to put this in is we make cuts on the bone in order to shape the bone so that the implant will go over it. And with a standard implant, the jigs that they give us make a cut, and we make this cut, and if your bone isn't average bone, there ends up being a cut surface of bone past the implant. Or there ends up being that the implant comes up higher than the cut surface of bone. And as Moby talked about, if the implant comes up higher than the surface of bone, it can then rub on the soft tissues that are around because it's sticking out past where the bone should have been. And if it ends up smaller than the bone, then this whole exposed surface of bone is able to bleed after the surgery, and it bleeds into your knee, makes the knee swollen, and makes it harder to regain your range of motion. So what ConforMIS can do is make it so that they can predict exactly what the cut surfaces of bone are going to look like in the patient's knee based on their three-dimensional model, and they can make the implant so that it covers all that bone. But it doesn't cover more than that. Next slide. So some of the off-the-shelf implant companies have tried to get closer to doing this. And what you end up with is this unbelievable different salad of implants that make it so that you have a million different sizes of femur, a bunch of different sizes of tibia. But the problem with that is that when you have a whole bunch of different sizes of femur to try to make that fit and a bunch of different sizes of tibia, you end up with several different sizes of the femur, of the thigh bone, matched. There's a plastic bearing between the two pieces of metal, and several different sizes of metal up here have to mate with several different sizes of metal on the tibia, and they all have the same plastic. So what that means is that you end up with mismatch between the plastic that's getting inserted and the metal that's on the femur.
Next slide. So what ConforMIS did is they came up with what's called a dual balancing system. And they matched, and what that means is instead of having one plastic insert that snaps on top of the tibia bone, you have two. And what it allows you to do is vary the thickness of each size so that it allows you a much wider array of solutions to try to achieve the proper ligament tension. It also allows you to restore the normal axis of the joint. So normally the knee joint is tilted about 3 degrees inward, and you can recreate that just by adjusting the sizes here. So instead of in a traditional one piece, what we call a monoblock plastic insert, to go up 3 sizes, you have solutions A, B, and C. But here, because we have 2 separate ones, we can have all these different combinations, 6A, 6B, 7A, 7B, 8C, and so we have 9 different combinations of inserts that we can put in to dial in the tension and make it really exact. Next slide, please. And so what that allows us to do is you can see these are 2 x-rays here, 2 different knee replacements, and you can see, there's a big difference in the thickness of the plastic between the inside and the outside here, and here's one where you don't need such a big thickness, but in both of them, you wind up with a knee that's mechanically well aligned, top to bottom, and you have good ligament tension throughout. If you just had implants where the thickness was the same on both sides, you would either have too much laxity on one, or you'd have lift off of the femoral component. And so only a system that allows you to balance them independently can restore that axis and the joint line and the stability all in one go. Next slide. So we talked a little bit about this abnormal liftoff, and this is actually really, really common with conventional knee implants. And what you see is in extension, when you bring this knee out into extension on the table and put your implant in it, and you sort of apply a force to it to rock it, it'll be perfectly stable. But as you come into flexion and you bend the knee this way, the femoral component will lift off the tibia like this. So it'll be stable on one side, but it'll lift off on the other side. And people notice this, and people are unhappy about it. And it creates a sense of instability, or I don't have confidence in my knee. It can cause swelling in the knee. And in some cases, this can be pretty extreme. So as we talked about before, the ability to independently adjust the tension on the in and the outside is how ConforMIS can get this liftoff number to 0. Because if you need a little bit of a thicker insert in there to tension that side, you have more options because you can independently adjust it. Next slide, please. So in terms of bone preservation, we talked a little bit about this as a design rationale. If you look at how much bone gets removed in a ConforMIS knee, the way we put these things in is we cut bone. We cut off the ends of the joint surfaces and we then cement this implant on there. Conceptually, if you think, this is part of my anatomy, the less of it I lose, the better. That makes perfect sense. And if you look at how the ConforMIS implant is designed, look at the thickness of the bone cuts. It's fully almost 2.5 to 3 millimeters thinner than a lot of the conventional implants. And overall, close to 30% less bone we have to take away to put this implant in. And as Dave mentioned, if you ever have to come back and redo something on one of these things, if you've already sacrificed a lot of bone, it can make revision extremely difficult when you're already missing a lot of that anatomy. Next slide, please. So this is sort of the production and delivery model as we talked about, and this is, if you guys ever had an opportunity to go visit this plant, it's really interesting. But we fill out the order, you get the CT scan, they make the implant, and then all the jigs are custom made, and these jigs basically are how we put it in. These jigs exactly fit on the surface of your bone. You don't have to drill holes in the bone, which causes excess bleeding. These things fit like a puzzle piece on the surface of the bone. And they're all 3D printed out of a sort of high-grade resin plastic. It's all sterilized, and it's packaged together in one nice little box here. So conventional implants, there's 10 or 12 heavy trays that have to come into the hospital and be sterilized every time we want to do one of these things off the shelf, because they have all these little separate jigs that have to be pulled out and put together. And with ConforMIS, everything, including the knee and what you need to put it in, comes in one little box. So in terms of just the efficiency in the operating room and the setup, it makes it much more efficient and potentially cost effective. Next slide.
So this is the
this is a little video
So
that, go ahead and, is it not going to play? It doesn't do it on, do mouse click, yeah. This is a video that was put together by ConforMIS that just sort of shows how it's all done.
I haven't seen it. So,
The proprietary iFit software converts the two-dimensional CT data into a three-dimensional model that replicates that patient's unique anatomical bone geometry.
Can you guys hear that?
In a 3D environment, iFit recreates the patient's natural J curves, corrected for deformity. From the 3D model of the patient's knee, iFit software builds the femoral and tibial implants to match the unique size and shape of each knee, which are designed to address common causes of patient dissatisfaction, including pain and unnatural feel. That same 3D model is also used to design patient-specific instrumentation for each step of the surgery, allowing for an efficient and simplified surgical technique. ConforMIS has pioneered additive manufacturing and 3D printing technology for producing single-use patient-specific iJigs. Instead of reusable instruments that require cleaning and re-sterilization, iJig positioning guides come pre-sterilized and are used on only one patient. iFit design and manufacturing technology enables mass customization, a term foreign to the orthopedic industry. Unlike any knee replacement available today, ConforMIS customized implants and iJig instruments are delivered pre-sterilized in a single box before surgery. greatly reducing hospital costs associated with implant storage and instrument sterilization. Simply put, iFit technology and just-in-time delivery model put ConforMIS in a class of its own with unparalleled speed of innovation.
So we talked earlier about what do we want as surgeons. What we want as surgeons is for patients to be happy, and we want that to be predictable. And as we plan each one of these surgeries, we spend quite a bit of time looking at patients' x-rays, trying to figure out ahead of time how exactly the cuts are going to look on their bone, exactly what that's going to do to the ligaments, and try to predict what kinds of pitfalls there might be as we go along through the surgery and how to head those off so that we end up with a knee that's perfectly aligned and perfectly balanced. And with old systems, with the traditional systems, that is something that we have to think through each of those steps and figure out how we're going to readjust the jigs that they give us to make them do what we need them to do. The cool thing with this is that what we get from ConforMIS is this piece of paper called iView, and we get a view of exactly what the jigs are going to look like when they're sitting on the bone, exactly what the implants are going to look like after they're in, and exactly what the rotation is going to look like. So we can sit initially and look at the x-ray of the patient and say, okay, this is the way I can envision this operation going. And then we can look at the iView and we can say, yep, that pretty much is what I expected it to look like. And then we can look carefully and it shows us exactly, this is how much bone's going to come off of this side of the tibia. This is how much bone's going to come off that side of the tibia. This is what it should look like when that happens. So when we get these jigs that are designed specifically for one patient, we can put the jig on the bone and we can look at it and say, yep, that looks just like what I expected it to look like from this iView. And it's remarkable how nice it is for us to be able to know ahead of time, this is what I expect it to look like, and then as we see it in the operating room, you say, yep, that's what I thought it would look like. Gives us great confidence as we make these cuts. Next. So we also are able to look at the tibia again. So this is your shin bone. And as we talked about earlier, the shape of this implant that goes on the top of the tibia, unlike the ones that are off the shelf where that would have been just a standard sort of oval, this one fits the back of the tibia. And so we're able to see ahead of time when we look at this before we go into the operating room, we can see, all right, once we make this cut, the tibia is going to have this funny little bump out the back of it, and the implant's going to fit right on that, and it does. But it still, again, gives us the opportunity to really visualize exactly what we're going to see in the operating room. Next. And what we end up with is this. What we want from a total knee is you want the tibia, the shin bone, to have a cut that goes straight across the top of the tibia and be perpendicular to the shaft of the tibia, which is what we get reproducibly with ConforMIS. And when we look from the side, we want the femoral components to fit right, and both components to fit right along the edge of the bone, which they do. And when we look from the side, we want the components to recreate the shape of the patient's original anatomy, which it does beautifully and predictably.
Next slide. So this has been around long enough now that people have been able to collect some clinical data, because that's ultimately what sort of, is the proof of the pudding, is that you have to have outcome studies that validate with clinical results that these things actually do what they're supposed to do. And fortunately, this has now been around long enough that we have both outcomes data, we have biomechanical data, and we have comparative data, which means we have data comparing ConforMIS knees to traditional knee implants to see how they stack up. And what we'll just sort of collectively summarize is that, what the data reflects is patients are happier, knees are moving better, and function is better. Next slide. So this is a study that was looking at sort of in-hospital outcomes. In other words, this is the acute perioperative setting, not where people a year after surgery. This is sort of what happens in the first 3 to 4 days after patients have a knee replacement. And what we typically look at that time period is how much blood did people lose, how much pain did people have, how long did they have to stay in the hospital, what kind of complications did they have, and where did they go when they left the hospital? Were they able to go home because they were functioning relatively independently, or did they have to go to a skilled nursing facility because they really weren't independent in their function? And what this data shows, and this is comparing ConforMIS knees to OTS, stands for off-the-shelf implants, is that invariably the length of stay was on average shorter for people with the ConforMIS knee. The transfusion rate, how many people needed blood products, was 2%, versus 11%. That's pretty significant because blood transfusions are not benign. Transfusions lead to a higher risk of infection. You can have transfusion reactions. Typically, people are stuck in bed missing therapy when they get transfusions. They're expensive. They lead to increased length of stay in the hospital. So avoiding transfusions is really critical these days. And getting a number down to 2% is really good. 15 years ago, 30 to 40% of patients got transfusions after knee replacement. So 2% is really remarkable. If you look at the difference in where did people go, only 2% of people had to go to skilled nursing facilities, compared to 11%. And again, that's a huge cost savings to society at large. It's much less expensive if people can go home. People are much more comfortable in their home setting if they can go home. And that's just a testament to the fact that people are functioning better earlier with these implants. And the adverse event, complications, related to surgery, blood clots, hematoma, wound healing problems, much less. And as Dave said, it's because you have less bone that's uncovered. Uncovered bone bleeds, knees wind up with a lot of swelling, hematoma that can lead to wound healing problems, infection, stiffness, increased pain, and all these things will limit function and lead to increased length of stay. Next slide, please. This is another one, similar type of data comparing ConforMIS to an off-the-shelf knee. And this is looking more at functional outcomes. And again, what you see is people in terms of their ability to walk, do stairs, and how quickly they got to 90 degrees of flexion, all around faster for people with the ConforMIS knee. And all of these parameters are statistically significant. Also, faster surgical time, lower drop in hemoglobin, which is blood count again, shorter length of stay, fewer need for ligament releases during surgery, which is that careful balancing that we have to do, because the jigs do that automatically for us, versus the off-the-shelf where we have to kind of try to fine-tune it so that we can take something that's average and sort of make it work for you. And again, the OR time, because these jigs fit quickly on the bone, it's a very reproducible operation. In terms of what we do surgically, there's really minimal learning curve to this because the basic techniques are similar. It's just that the implant and the jigs are better. And so because this is sort of nicely prepackaged in a box that gives you everything you need, you can move through these steps quickly and the operation is faster. That means less anesthesia for the patient, less blood loss, less risk of infection, fewer side effects from anesthesia. All those things are positive. Next slide. And finally, looking at knee outcome score. So KOO stands for Knee Osteoarthritis Outcome Score, and overall patient satisfaction. So as we talked about earlier in the talk, this is the 20 to 25% of people that are not fully satisfied with their knee. It doesn't mean it's an agonizing pain, but it means relative to what they were expecting or what they wanted, they haven't achieved it with their conventional knee. That's 1 in 4 people. I mean, that's not insignificant when you think about it. And with ConforMIS, they're bridging that gap, which is what we want and what you want. If you can get 95% of people have good to excellent results, that's a very good operation. That's amongst the best operations that you can do in medicine. It's impossible to get to 100%, but 95 is as good as you can get. Next slide, please. I think the other thing is ConforMIS fits into a larger trend in what we call rapid recovery. Joint replacements now, 15, 20 years ago, people would stay in the hospital for a week or two. It was like a vacation. You'd lay in bed, for a couple of days and kind of do nothing with your leg wrapped up. And it's a whole different scenario now. We get people up and moving. People are up out of bed on the day of surgery. Some people are leaving the hospital the very next day because, we use a lot of different techniques, better pain management, faster rehabilitation, preoperative patient education and engagement, preoperative physical therapy, all designed to get people up and get them moving so that they could take advantage of a knee that's more functional and get it functioning faster. Next slide.
So we've been working hard here at Wentworth-Douglass on creating a collaborative team approach between our practice, which is a private practice, the hospital, all different physical therapy places that people go, trying to get that so that we're all working toward the same thing. So the first is preoperative evaluation and screening, making sure that all medical comorbidities are as optimized as they can be. If you have diabetes, if you have high blood pressure, if you have heart disease, making sure that those things are in as good shape as they can possibly be ahead of surgery. Anesthesia and pain management. There are a lot of techniques that can be used both by the anesthesiologist as well as by us in the operating room to decrease the amount of pain that people have, which number one makes things more comfortable and makes it a more pleasant experience, but number two allows you to get up and going much more quickly. Surgical technique improvements, as we've been telling you for the last 40 minutes, 45 minutes, the patient-specific implants that we have with ConforMIS really give us the opportunity to improve our surgical technique, make it more predictable, and make it work for patients better. Medical co-management. Here at Wentworth-Douglass, we have hospitalists who are internal medicine doctors who are here in the hospital that help us manage all of the medical problems that people have in addition to their orthopedic problems, and we work very well with them. Physical and occupational therapy are important parts of both helping you relearn to get around, get in and out of a car, get up and down stairs. We have a room upstairs on the orthopedic floor that has a model of a car so that you can practice getting in and out of the car seat, so that when you go to get in the car to go home, that's not the first time you've tried that. There are stairs up there so you can practice on stairs. So you know that when you go home from Wentworth-Douglass, you are prepared to do so. Social work and discharge planning and nutritional support. From the time that before you come to the hospital, people are tuned in to helping make sure that you're as safe as you can be to go home and that you go elsewhere if you need to. Next. So the final thing, I'm sure many of you have heard a lot of advertisement about partial knee replacement. Out in the radio, papers, magazines, there's a lot of talk about partial knee replacement. So as Moby was talking about at the beginning, you can have arthritis either in all three compartments of your knee, where it's underneath your kneecap and on the inside and the outside part of your knee, or some people have arthritis on one part of their knee, just on the inside or the outside. And for years there's been an effort to replace just the part of the knee that has arthritis. And intuitively that makes sense, to leave the part that doesn't have arthritis alone, replace the part that does have arthritis. The problem with that has been that the success of that over the years, despite multiple different kinds of implants, has not been terribly good. And the people that we'd like to do that in are young people rather than old people. And the amount of stress that there is on the implant has made it so that they don't last quite as long as they might. Having said that, though, 20 to 40% of people who have knee replacements really have arthritis that's limited to one area of the knee enough that they could have gotten by with a partial knee replacement. The advantages are that all of the ligaments stay intact with a partial knee replacement. More bone is left behind, so again, in terms of being able to do something later, it's less invasive, less bone is removed. There's less blood loss, it's a smaller incision, recovery's faster. Next. So with ConforMIS system, it was actually initially designed as a unicompartmental implant. So the same technology that allows a complete knee replacement to be customized allows a partial knee replacement to be customized. Next. The other thing that's out there is Makoplasty, and this is something that several of the hospitals around are starting to get, that has been advertised at Lakes Region and a number of places. And we looked at this as a technology before deciding to go with ConforMIS. And what this is it basically is a robot that uses 3D technology, again, to guide our hand as we are taking that bone away. So what it does is, the way that works, however, is that we have to drill extra holes in your tibia down here in your shin bone so that there's this array of sensors that a sensor on the other side of the room can pick up. We have to drill extra holes in your femur in order to put implants in there. And now you have extra holes in the bone that you didn't have before. Because of that, the operation takes longer rather than shorter, whereas with ConforMIS, when you have these jigs that are fit directly for you, we're able to get you out of the operating room and have you have a shorter operative time, whereas with Makoplasty, it ends up being a longer operative time than conventional surgery. And currently, it only works for partial knees, where ConforMIS as a specific implant can do both partial knees and total knees, whichever one is appropriate for you as a patient. And then finally, Makoplasty still is using an off-the-shelf implant. So you have a robot that helps you make a cut to put in an implant that wasn't designed for you in the first place. So we looked at both technologies, and we really strongly feel that ConforMIS gives our patients an advantage that a robot doesn't. Next slide. So ConforMIS in the end is part of this mass customization trend. You can go online, you can order your own tennis shoes, you can order your own colors of M&Ms, you can go through the Chipotle line, you can have your burrito exactly the way you want it. This is part of that trend, to have you have an implant that fits in your knee exactly the way it was supposed to and gives you a knee back that feels as close to the one that you were originally given as it can. Thanks. So we're happy to take questions, and then at the end, after some questions, we have models of what these implants, some of the real implants up here, and we'd be happy to sort of talk to you about, show you how all that works. Is that? Yeah.
Can you do a full knee replacement on a knee that has already been operated on that you're not totally satisfied with? I've had a right knee replacement, and I have swelling on the right side, and it's been there for quite some time. I have the clicking, and I think the surgeon did the very best he could, but I'm not totally satisfied with it. And I do need to have the left one done also.
Yeah, so this can't be used in a revision setting. And it may be, this may be like a future trend in the development of this technology. I mean, I think like a lot of technologies like, space travel, you sort of start small, and as you perfect things and get more data and figure out what works. I mean, these may be future trends for where this technology is going to go, but it isn't yet to a point where we can do revision of a previous knee with it.
Okay, so this knee to be redone would be a conventional rework.
Yeah. Yeah. That said, people who have had prior surgery that wasn't a replacement, in other words, if you had an old ACL tear or a fracture and you have a plate on the top of your tibia bone, the engineers can work around some of that stuff, even if there's sort of a, the x-ray from the CT scan kind of bounces off the metal. They've developed sophisticated algorithms where in other, post-traumatic or post-operative settings, they can still do it, but just not revision of a previous knee replacement.
Would it be advisable to have the conventional rework done at the same time as full knee?
You could do it, if you're somebody who is like reasonably healthy, and there's places around the country that will do this. They'll do a revision knee on one side while they're doing a primary knee on the other side, but it's a lot to go through. and conceptually it might be sort of difficult, like this one is coming along great, this one, and so that sort of differential might be hard for your mind to, yeah, and so it might be the type of thing where people say, look, don't bite off more than you can chew, pick whichever one is worse, like get that one good and then worry about the other one. And nobody likes to come back to the operating room again and again, and the concept of like one recovery and I'm done is nice, but then there's sort of patient safety, blood loss, operative time. You got to take all these things into consideration. Would the rehab on one affect the rehab on the other? Would that limit the outcome of your ConforMIS knee if you got the other one revised at the same time, or if you had a complication like that one got infected because it was a more complicated, you know what I mean? You could potentially open up, and these are all hypothetical things, but there's these sort of can of worm issues that you could say like,
For years, the data suggested that we should steer people away from getting both knees done at the same time. That the length of the surgery, the amount of blood loss, the impact to your system as a whole was just so much greater by doing both knees that it didn't really make sense to do both knees at once. As the systems have gotten so that we can do these more quickly and people are under anesthesia shorter a period of time, there's less blood loss, particularly with ConforMIS under those ways. I think certainly in my practice, I work a lot less hard to talk people out of doing both at the same time than I did before. But I think if you were to do a revision and a primary at the same time, you're back up into the length of surgery and the amount of blood loss that I think we were thinking about 10 years ago for doing 2 primaries, and I think just the medical risk to that would be significantly higher. So we're less reluctant to do bilateral now than we were, although still it's not our preference. That's probably a lot to bite off. Yes, sir.
Is this same technology being applied to hips as well?
Yes, it is. It's not. The hip has been designed, and it is currently in the process of FDA approval. And I think that can be a long, drawn-out process going through FDA approval. So the bottom line is the technology is there, the design is there, their ability to manufacture the implant and the cutting jigs has already been done. And now they're waiting for the stamp of approval from the FDA that says you can release it to the market. And as of now, I don't think there is a firm release date yet, but it's coming. Am I correct on that, Steve? Is that a fair assessment?
Same thing about shoulders.
Yeah, shoulders is, I guess what I would say is this concept is perfect for shoulder replacement. Maybe not every single shoulder replacement, but definitely, if you start getting into, well, the rotator cuff is shredded and, they've had previous surgery, that could technically get complicated. But starting off with simpler cases of routine osteoarthritis or even just plain osteoarthritis with an intact rotator cuff, the concept of a custom patient-specific implant where they can restore the alignment and get the joint line back out to where you want it, so the muscle tension, this concept is perfect for it. But the way these companies work in product development pipelines, there's always like a pipeline to it. So the company, because they have shareholders and investors, they have to sort of think about, we want to get this project out to market. So right now our focus is FDA approval for the hip. They've also released what's called a posterior stabilized knee. So the knee that we've been talking about is what's called a cruciate retaining knee. And that means the posterior cruciate ligament is preserved. There's also a type of knee called a posterior stabilized knee where both of the anterior and posterior cruciate ligaments are cut. And honestly, there's not a huge performance difference. It's usually surgeon preference. Which kind of system did I train on? And the long-term outcomes data, longevity, durability, function, it's pretty much the same. But there are specific indications where you would choose a posterior stabilized knee, severe deformity, people who have like a really bad, what we call a valgus knock knee deformity like this. Those are ones where you would automatically probably choose a posterior stabilized knee because leaving the posterior cruciate ligament can sometimes make it too hard to correct all the things that you need to correct. That has just gotten released, and so they're sort of like, okay, we got the posterior stabilized knee to market. Now we're going to get the hip to market, and so they this is the way the development pipeline goes. And I think that they are interested in considering it, but as of now, there's no sort of firm commitment to do it. But this company is relatively young, and this technology is always getting improved. And I think what we'll see is as years go by, they're going to start solving a lot of different problems. Because really, it's just like a platform. Once you have imaging, you have engineers and software and workstations, and you just need to feed it data and then build the algorithms, and then the printers can just make it. You had a question.
How long at your Seacoast Orthopedics, are you the two? It's kind of twofold, actually. How long have you been doing it, and the hospital here, how performing these
Doing
procedures?
ConforMIS?
Yes.
When did we start? We start June? I thought it was earlier. I thought it was earlier than that.
June was the first one that we did.
So it's been about what, 8 months, something like that. But as Moby said, the technique in terms of what we do as surgeons is in a lot of ways simpler than what we were doing. It's still the same incisions, it's still the same saw in our hands, it's still the same, everything that we actually do through the operation is the same, except for now it's more predictable and easier. So we've been doing it for 8 months or so and are really happy with the outcomes that we're getting. But it's a relatively new technology, but it's not there are a lot of surgeons out there that use, I had a surgeon that I trained with that used 4 or 5 different companies' systems and just sort of depended on what rep took him out to dinner most recently. And that doesn't happen anymore. But it really, I mean, they're all similar enough. Yes?
At what point did you decide you need to get the ConforMIS knee? I've got arthritis in my knee. I've had 2 surgeries for meniscus. In my second round of the injections now. I know there's another round that's a 3-part one. At what point do you say enough of that, let's just do the knee? Or do you have to go through all of that before you can say, all right, this person needs the knee?
Well, so this is, I always say this and it makes it sound like it's cosmetic surgery, which it's not, but this is a lifestyle operation. I mean, this is an operation to allow you to get back to doing what you want to do. You're not going to run after this, though. So this allows you to get back to hiking, to skiing, to playing golf, but probably not to running. So that's a complicated answer, and it's an answer that's different for each patient, right? I mean, if basically the timing on when it's time to do a knee replacement is when you have tried all of the things short of a knee replacement, the injections, those sorts of things, and you're not happy with the way your knee is. And when you get to that point, it's time. You know, we used to tell people you have to be 65 or older. We used to try to really push people a lot later with the idea that if you put a knee in a 65-year-old person and it lasts them 20 years, it's a pretty reasonable chance that's going to last them. They're not going to have to do this again. Whereas if you put it in a 50-year-old and they go out and they hike 1,000,000 miles and really put a lot of strain on it, the likelihood is that they're going to need to do it again. But I think the thinking over time has changed from, well, why make somebody suffer through their 50s to get to 65 so that they can have a knee that will last them 20 years if they're lucky enough to live that long? Why not give them a knee that feels good during their 50s? So I think we've, over time, we've sort of, patients expect more, and I think we've gotten comfortable that we can do this in younger patients, particularly when we can give you a knee that fits you as well. So the timing is really, I'm not able to do what I want to do, and the simpler solutions don't work.
Yeah, typically what we tell people is, you're going to know when it's time. You'll know. You'll wake up one day and say, I'm done. The other part of your question is it mandatory to do all this stuff? It's getting to be, with a lot of insurance companies, that the way it works is if people come to us and say, I'm here, I'm ready, sign me up, there's sort of a pre-approval process that has to go through the insurance company. And we are seeing in some cases insurance companies say we won't pre-approve it because the patient has not had a trial of non-steroidal anti-inflammatory medications, physical therapy, and or injection therapy. And this is kind of the way medicine is moving. It's like, you got to check the boxes. And so there are times where people will come to us and say, ready to get this done. And we'll say, okay, here's the deal. We're going to give you a prescription for Celebrex. You're going to go do 6 weeks of physical therapy, and we're going to check off a couple of boxes, and then they'll approve it. So, and some of it depends on the insurance company, and some people have already been through all this stuff, but some people will say, hey, look, like my husband's going to retire at the end of next year. I'm still on his insurance. It's a good time. I'm healthy. I need it, and I don't really want to waste a whole lot of time checking these boxes and doing injections. And quite frankly, I don't really want a needle in my knee, And so there are people, who are under circumstances where they're like, I'm ready to go right now. And some insurance companies will allow that, and sometimes we have to play this game a little bit, to get the pre-certification, and it's the world that we live in. So
that's what's happened. I've got my second cortisone shot. I thought I was getting inflexible. They said, no, you have to have 2 cortisone shots.
Yeah.
So I'm jumping through the hoops and checking all.
I know, and we hate this stuff. I mean, nothing drives us crazier more than when we get a denial from an insurance company and we got to call some 1-800 number and go through a phone tree and talk to, somebody sitting behind a desk and argue with them. And we're getting it more and more.
But the other piece to your question, though, you said you've had 2 knee scopes, is what's the indication for that. And we used to think that if somebody had pretty significant arthritis, that we could put a scope in their knee and sort of do a cleanup, a tune-up, and that would buy you a couple years before you needed your knee replacement. And probably 10 years ago, there was a really well-done study done in the VA system where you could only do this with veterans. But they talked these guys into they all got anesthesia, they all got an incision and got a stitch put in, but only half of them had the scope put in and the other half didn't. It made in people that had severe enough arthritis that really they were candidates for total knees, it didn't make any difference to put the scope in. And then we know that in people that have a knee that's perfectly normal and they have a meniscus tear, it works great. The problem is the people in the middle. And there's more and more studies coming out over the last couple of years, mostly out of Europe, that are showing that if you have pretty significant arthritis, probably a knee scope doesn't do a whole lot for you. So the days of kind of 2, 3, 4 knee scopes before you get to a total knee, I think, are gone. I think that, you know, maybe once to see whether you can clean stuff up, but it doesn't make a whole lot of sense to just keep doing knee scopes.
7 and 14s.
Yeah.
Piggybacking on an earlier question, realizing this is a relatively new surgery and you started with in June, ballpark, can you tell me how many have the two of you done with the surgery?
80, which is a lot.
80.
80 thus far, which is quite a bit. It really is. A lot of experience.
Yeah, like Dave said, the beauty of this is like I started doing the direct anterior total hip replacement probably 5 years ago. That was a whole new surgical approach to the hip. You know, traditionally people would go through the back and then somebody, you know, and then they began to sort of rethink about this anterior approach, which was really an old approach, but somebody had the idea that if you go through the front, you actually don't have to detach any muscles. And they sort of redeveloped it, perfected it, came up with a whole bunch of new instruments, and then it caught on like wildfire. Everybody that came into our office who wanted a hip replacement was, do you do the anterior approach? Because I hear that's like the only way I should have it done. And so we kind of realized like we got to learn how to do this because this is what patients want. So you want to sort of meet your patients' expectations. And for that, because it's a whole different surgical technique. It's a whole different approach, different muscles, different anatomy, different way of looking into the joint and the relationships between the bones. And people say the learning curve for that is 50 to 75 cases before you completely just have your head wrapped around it and you know, and you don't have to think about it anymore. It's just automatic muscle memory. You just kind of go and you know it. And for this, because it's the same exact surgical approach, getting into the knee entails nothing different conceptually, and perhaps even less, because we don't have to do a lot of releases of the soft tissues, a lot of those sort of nuances that it really is a gestalt. It's kind of like, I'm looking at it with my eyeball and it looks pretty good, but maybe if I just, you know, I mean, there's a lot of sort of judgment and eyeballing that goes into a traditional total knee, and because we don't need that with the ConforMIS, we actually have to release less tissues, but the basic way of getting in there is exactly the same. And the order of steps is exactly the same in terms of you cut this bone and then that cut and then this cut. And so in terms of a learning curve, there is almost no learning curve because it's really, other than the jigs that we're putting on and the stuff that we're gluing in, it's almost exactly the same operation. It's just that we can do it with less blood loss and less tissue trauma because of the instruments that we have to do it. So,
Yes, sir.
How long, after you get your first knee done, how long do you expect to get the other one? You have 2 knee replacements that can be done.
So there's no exact right answer on that. You can do them both at the same time.
If you don't want them,
If you don't want them both at the same time. So there are surgeons around who would do them the next day. We don't think that makes a whole lot of sense. There are probably, by the time you're about 3 months after your knee surgery, you're at a point where that knee's pretty functional, you're getting around on it, you really trust it. Really, this operation takes a good year before you feel like it's your knee. It really does. It takes it, but at 3 months, most people are really pretty functional. So for me, I think 3 months is a pretty reasonable number to wait. You agree with that?
mm-hmm. Yep, I agree. But beyond that, you can wait as long as you want, you
Right.
know. So.
and interestingly, sometimes people have pretty bad arthritis in both knees. Their x-rays look pretty bad in both knees. And once you replace one, they sort of are walking a little bit better. And the other knee actually sometimes feels a little bit better, and they buy some time on the other knee because because you're getting around a little bit better, walking a little bit better, able to exercise a little bit more, and that makes the other knee feel a little bit better. So sometimes people expect to do it in 3 months, and it ends up being longer than that. Yes?
The video spoke to this a little bit, and that is if you're taking a CT of a diseased knee, parts are not good.
Right.
So can you speak a little bit to the algorithm or the formula that compensates for the deformity that a patient has when they develop the new components?
Yeah, so we talked about this a little bit yesterday. About a week and a half ago, ConforMIS called me up, and ConforMIS is it's like every implant company, J&J, Biomed, Zimmer, Vanguard. They're big companies, they're publicly traded companies, they're traded on the stock exchange, so they have shareholders and investors. And so yesterday I got invited down to ConforMIS just to provide some surgeon input to some corporate investors that were looking to, do we want to sink some money into this company because it looks pretty exciting? And this was one of the questions that came up. So I actually heard this directly from the mouth of the CEO, who was the founder of the company, who was the radiologist that sort of figured it all out, And it started with we can get a pretty good map of the knee anatomy, so can we, and basically what they did is a lot of studies to see if, based on the remaining information that we can gather from that patient's knee, the flexion axis, things of this nature, can we extract enough information to basically figure out what it was before it got really deformed. And there's enough surface information left in an arthritic knee that they can basically extrapolate what these J curves are, where the joint line should be, what the rotation of the component could be, based on information that they can garner from these CT scans, and based also on experience. And so what they have now is a huge database of experience where they can, perfect these algorithms, based on all the cases that they've done and the feedback that they get. And so, I think they've gotten it to a point now. We're lucky because we sort of got into this game when all these algorithms had been perfected over the years, and the company's done like an amazing job of working this stuff out. And really, it's the engineers that sit at the workstations that figure it out. And these are people that are like incredibly smart at what they do. And for us, the surgeons putting them in, it's like we're always like just amazed that you can take a knee, and some knees that we're used to like really thinking about it, like this is a knee that has like a lot of malalignment, and we're going to have to like cut the bone like this and only take a little bit there and release that side and do this to try to get it all balanced. And when one of the first badly deformed knees that I did that was like really badly knock-kneed, I was talking to Steve Huff, who's our ConforMIS rep, and saying, I think I'm going to have to, maybe cut a little bit less bone here and probably release that ligament. And Steve and one of the engineers said, no, just trust the jigs. Do what the jigs tell you to do. Don't do anything else. Just trust the jigs. And so,
given that the jigs are also customized, are they just thrown out after the surgery?
Yeah.
To the patient?
No. It's biohazard waste. Yeah, those are thrown out.
The other thing
it's amazing if you just trust the jigs and do what they tell you to do. It's incredible how it works, and you're like, wow.
The other thing that's cool about this system is that the precursor to this that other companies have done. So I tried this with Smith & Nephew, which is another one of the companies that's out there, where they were customizing the jigs. You were still putting off-the-shelf implants, but they were customizing the jigs, and they were doing it based on an MRI scan and trying to look at what people's cartilage looks like. And the cartilage is much less predictable than the bone, and this is doing it on CT scan based on the bone. So bone's nice, hard stuff we can sort of really reference nicely off that bone. And so that I think is a big advantage of this, that the bone is less deformed than the cartilage is. Yep.
Who picks up the cost of customization? I mean, it sounds like it's less cost to the hospital on some level for their sterilization and the efficiency of it all, but our insurance is paying for this?
Yeah, we have had like not many at all, but usually what insurance companies may refuse to pay for is not the implant, because the cost of the implant really it's very comparable. It's the CT scan, because they'll say, patient doesn't need a CT scan, they have arthritis. And some of those will wind up, making a phone call to the company and arguing them. And I'd say in the majority of those cases, we can convince the insurance company to pay for the CT scan. That's a little bit of an added cost, but when you stack that up against a shorter hospital stay, lower transfusion rate, less discharge to rehab, it's more than cost effective. And the other thing is, other companies. You saw that slide that said size salad, and there's 8 different sizes of femur and 8 different sizes of tibia, and all the plastic inserts to go with it, and the patella components and this and that. And so, for those companies, if you're going to do 3 total knees in a day, they need to have 3 full sets of 8 sizes. They need to bring in 25 boxes worth of inventory, and that's just for one surgeon in one hospital. So most companies in the course of 1 year for off-the-shelf knees will have $250 million in inventory sitting on shelves, floating around, between hospitals, that they basically are just hoping to sell. And they always have lots of, it's like a car lot. You drive by I drive by the Nissan lot in Somersworth, and I'm like, there's like 100 cars on this lot. Like, who's gonna buy 100 Nissan cars in the next month? But because this company has no inventory, the only inventory they have are the ones that they're getting ready to ship out. And so because they don't have to carry $250 million of inventory, it's actually a much leaner production model for the company that they can keep the price comparable. They don't have to jack the price way up because they don't have millions of dollars sitting on the shelf. So when you think about it from that perspective, you're like, it's ingenious. There's no inventory. Come on, people.
One more, what you got?
Does the CT scan, and I've already had mine, does it really compensate for every facet that you've already gone through? 5 surgeries already in my knee transplant. Is it going to take into consideration all of those factors? Can it?
So it will take in, it's going to take in as many factors as it can in terms of the shape of the implant. It will make the implant fit on your bone, for sure. There's no question about that. The question is what's going to happen with the soft tissues, and is it going to do the ligament balance stuff as well as you hope it would? And we have a lot of experience doing ligament balance with knees, with off-the-shelf systems that are much harder to balance than this. So the answer to that is that, yeah, unless there's something really outlandish, if the surgeon that's going to put your knee in has looked at it and thought that ConforMIS was a reasonable system, it's going to be able to account for that. Huh? So
yeah, and plus, a lot of the stuff that you may have done is stuff like that references the cartilage. It's cartilage transplant, it's cartilage wear. And so again, if you're referencing bone, and you may have one small area where you had sort of an osteochondral transplant or something, that's going to be like, a dime-sized thing. But really, they're mapping the perimeter. You're putting an implant that's covering the perimeter. So if you have a little area where there's a bony defect, it's not going to be an issue.
And you said that metal might fall off the CT scan, but the transplant wouldn't.
I had a patient that had a big plate on the tibia, and I said, oh, I guess I can't do a ConforMIS on this because there's a big metal plate on the tibia. It's going to completely throw off the CT scan. And so I didn't. I did an off-the-shelf total knee, and then later on I just happened to be talking to the engineer, and I said, oh, hey, listen, just as an aside, I had this case that had a big metal plate on the top of the tibia bone from an old tibial plateau surgery, and he said, we can do those. So, and I was like, oh, that's too bad.
What are the limitations, like, well, this gentleman can't run, but he can hike, is it weight limitations, or is it wear, or what are the limitations going forward after the implant?
You want to take that?
Yeah, there aren't really specific limitations. So the more impact loading you have on it, so these implants are cemented to the bone, and that cement is somewhat brittle stuff. So you don't want to run because you don't want to have that cement between the bone and the implant crack. Outside of that, pretty much anything you want to do is fair game. Hiking is fine, walking's fine, skiing, we have people that ski, we have people that play, I don't know how many people we have playing singles tennis, but we certainly have people playing doubles tennis. So, I mean, you can do more or less what you want to do with it.
You could run.
Right.
The question is, should you run?
Right.
And so, and actually, people have done studies around the United States where they will survey 1,000 orthopedic surgeons who do joint replacement all over the country just to try to get an answer for a question like that. You know, and they'll send out one of these Survey Monkey things that has a bunch of questions. How do you counsel your patients about, do you have specific restrictions that you put on them? Do you let them do whatever they want? Do you counsel them about restrictions? Do you let them do things within reason? Do you put major restrictions on them? And the bottom line is there's no consensus about this answer. And there's surgeons out there that say, look, you're taking the risk. It's your knee. I'm telling you, if you run on it, it's going to wear out prematurely. If you live to run and you think that, you know, we're all going to be dead in 5 years from World War III, run. You know, I don't care. And then there's other surgeons that are like, if I'm going to operate on you and you're going to be my patient and we're going to have this relationship, you're going to sign a contract that says you'll never run again. And so every surgeon is a little bit different, and it sort of just boils down to a conversation about this is, you know, and sort of coming up with a mutual agreement about what it boils down to is educating patients about the risk for premature wear, and impact is the big thing. Jumping, you know, playing basketball, things like that, where you're.
Yes, ma'am.
If you have less eyeballing as a doctor, less thinking, then the operation's going to cost a lot less.
Cost versus eyeballing. That's never been studied. If the operating, if the OR, if the surgical time is a lot less, yes, surgery gets billed by the minute. Yeah, so if it takes you 16 minutes less to put one of these things in because you don't have to recut the bone. So I did one on Monday that was a traditional knee implant for a specific reason because the patient had, you know, a certain type of deformity. So right now, ConforMIS can capture about 85% of all knee replacements that need to be done. There are rare cases where the deformity is so extreme or the anatomy is just so out of whack that you may need a conventional implant because you need a knee that has more built-in constraint, because the ligaments, no matter what, are just going to be too out of whack, too stretched out or previous tear. And so there are a fairly, sort of less than 15% of cases that just sort of fall outside of what the technology can handle. And this happened to be one of these cases. The guy had extremely hard bone. I had to recut 4 or 5 of the cuts because you put the trial in. No, it's not right. I got to recut the bottom of the femur. Then if I recut the femur, I got to recut these other cuts that the implant fits. And it's pretty close, And so you end up making these fine-tuning adjustments that take time during the case, versus this system where it's sort of done all the thinking for you and you can just make the cuts and put it in. And so that definitely can save time, which can save money because there's less, sort of fiddle factor with it.
Recovery time, big concern for anybody going through this type of procedure. I know you and I have talked, and it's like we're walking the next day, but realistically, how much time does it really take to be back to normal everyday functions? We're talking weeks, we're talking months, we're talking.
Yeah, it's totally different for everybody, and I think we would be lying to you if we told you like this operation is a miracle. You're going to be playing golf in 2 weeks. I mean, it's a knee replacement. It's an invasive procedure. You still have to cut the knee open. You got to make cuts on bone, and it takes time to heal, and it takes patient dedication to the rehab program. And so there's one answer to this question is we get people out of bed the day of surgery. They're walking that day. They're walking the next day twice. We want people to walk 100 feet down the hall and go up and down 8 stairs before they leave the hospital, and we want them to have 90 degrees of flexion. And so we have sort of these benchmarks that we want people to achieve, and so that's sort of one way of looking at the recovery is how quickly am I going to get to 100 degrees of flexion. But then there's the when can I drive? When can I go back to work? When's it going to feel good enough that I can take the dog for a 2-mile walk? And the answer is it's completely different for everybody in terms of how bad was your knee beforehand, what medical factors might inhibit your healing process. And, people have different pain thresholds, and all these things factor into it. So as a rule, because we oftentimes have to make generalizations, we'll say, by the end of the first month, you're going to be still kind of sore, and it's going to swell, and if you're on it for long periods of time, it's going to let you know, and by the end of the second month, and you'll be cursing us by the end of the first month. You'll wish you never did it, not really, but by the end of the second month, it'll be getting there, you'll be getting there, but like it's not all. By the end of the third month, you'll be telling your friends you're glad you did it, and you'll be getting around pretty good. But the healing process takes up to a year. Like if you feel the knee at 4 months, it's still warm. That's because there's still healing going on. There's still collagen maturing and scar tissue forming. And so, it may tend to get stiff. If it's in the same position all night, when you wake up, you're going to have a little bit of startup stiffness. You might have swelling if you're on it for a long period of time. And those are it's sort of like we tell people, by 3 months, you're probably going to be about 75% of the way there. And the last 25% takes 9 months. The healing process has to mature. You got to get your quad strength back, and that stuff just takes time. But functionally, by 3 months, we would tell you, you can kind of do whatever you want at this point, but you're not going to be as good as you're going to get.
And most people, it's interesting, but the operation obviously hurts. I mean, people are pretty sore in the first few days afterwards, the first few weeks afterwards. But it's interesting, usually by the time people come back to see us at a week or 10 days out in the office, most people will say, that pain I had is gone. My knee hurts, but that pain that I had is gone. And that's a different thing. And I always feel really good about that. People say, oh yeah, it really hurts. And I say, yeah, but does it hurt different? And if it hurts different, I usually feel pretty good about, okay, well, so the soft tissues are healing and you got to get everything moving again. But that arthritis pain, people typically say, that's gone.
So you must recommend physical therapy after surgery, right?
Yeah, we do. It's critical. I mean, this is like a team approach. You know what I mean? Like we can do the best operation in the world and have a perfect looking X-ray, and a knee that when we close it up on the table looks and feels perfect. And if patients, don't do the rehab on it, it won't be a good functional knee. And so it's kind of like, that's why we tell people, like, you got to be ready if you're going to embark on this journey. Like, you have to be mentally prepared for it, because you got to be committed to doing that therapy, and you got to do it, and you got to sort of, grit your teeth and do it. And I tell people routinely, you got to do it for a year. You're not going to go to physical therapy for a year. You may go to therapy for 6, 8, 12 weeks, but you got to exercise this thing for a year, because that's how long it takes quad strength to come back, and that's really critical. And we're getting people into therapy beforehand now, so that they can start these exercises beforehand to sort of get in shape, so that as they come into the surgery, they already have a jump start on it. And the other thing that we're doing is we're really, we're trying to encourage people to go home right from the hospital. Some people can't. There are circumstances where people need to go to rehab because they don't have help at home, or they live alone. They have a lot of stairs to go up and down. Maybe they have some medical conditions that need to have an eye kept on them. But if patients can go home, we encourage patients to go home and try to get right to outpatient therapy as quickly as they can, because there's more tools at their disposal, there's more machines. Home therapy is not bad, but they're sort of limited in how much they can do in the home. And so, and the other studies have shown that when people go to skilled nursing facilities, there is a higher complication rate. There's these skilled nursing facilities, although they're quite good, there are sick people in them, there's more bacteria in them, there's a higher infection rate, there's a higher complication rate, there's a higher readmission rate. And maybe it's because some of the patients that have to go there are on the sicker side, so it's pre-selecting out patients that are predisposed to it, but some of it may just be related to the environment that these people are in. And the home environment tends to be more comfortable for people. So, the ideal scenario is the patient that can go directly home from the hospital and within a week get into outpatient therapy and get it going. And to the extent that people can plan that in advance, that's the idea. Not everybody can do it.
I'm an OT who works in home care, and what we're getting right now is we're getting bundled patients. So you got to think, if you have your surgery and you're being discharged on Friday, you don't want to be sitting around 2 days doing nothing. So a lot of our patients, they're seeing 5 days for PT, I'm OT, and then usually a vow for OT, 1 visit, unless they really have other issues. Then within a week, they're an outpatient.
Thank you. So we do have a bunch of models and stuff up here if you want to come and look. Thanks.